Hello, good afternoon, everyone, and welcome to this mini symposium on COVID-19 coagulation and thrombosis issues. My name is Marcel Levi. I'm Professor of Medicine of University College London and also at the University of Amsterdam. And until April, I was Chief Exec of University College London Hospitals. Now I've moved to the Netherlands and I'm Chief Scientific Officer of the Netherlands. And I'm co-presenting this with Sue Pavord and with Andrew Retter, who I will introduce in a second. Thank you all for joining us. It is fantastic that so many people are joining us for this mini symposium. I'd like to thank the Royal Society of Medicine for taking the initiative of doing this. What we were planning to do is to speak about 15 minutes or so on coagulation and thrombosis issues in patients with COVID-19. Then we will have another 15 minutes talking about the thrombotic complications of COVID-19 vaccination. And then we will have ample time to address any questions that you have submitted already or that you can actually submit through the Q&A button on your Zoom program. So let me first introduce the co-presenters of today. We have Dr. Sue Pavord. She is a consultant hematologist from Oxford, and she's also chairing the expert hematology panel on the topic that we're discussing today. And we have Andrew Retter. He is a consultant of intensive care medicine. He's an expert in the area of ECMO, but also on thrombosis on ITU. So we're very happy to have both with us today. And I'm sure we can actually address current insights, knowledge, and facts about coagulation thrombosis in this COVID-19 pandemic and the vaccination effort. So let's start right away and maybe just give a quick wrap up on what we actually see when we are studying coagulation in patients that present to us with COVID-19. And maybe I'll start with Sue. Can you please give an overview on what clinicians are expected to see when they do coagulation tests in patients who are presenting with COVID-19?
Okay, thanks very much, Marcel. Well, we know that COVID-19 is capable of producing this very, very pro-inflammatory state. And the host response is this huge outlay of cytokines and interleukins and anti-TNF alpha. And what that does is increase platelet activation, endothelial cell injury. And when we look in the laboratory, we will see we'll see platelets clumping on the blood film, particularly in severe COVID. There's a lot of platelet clumping, show that the platelets are very much involved, even though the platelet count is generally quite normal, the actual count. We'll see a very raised fibrinogen and very raised D-dimers. We'll also see a high neutrophil to lymphocyte ratio. In fact, that ratio is higher than it is for other viral infections.
Okay, and can you elaborate a little bit, Sue, on the D-dimer, because that's an eye catcher, I think, for many people. In how many people approximately will it be elevated, and what is it? Just a little bit elevated, or is it really excessively high?
Well, certainly in people who get this cytokine storm, the D-dimer is very elevated, and it's really a marker of the pro-inflammatory response. So D-dimer is an acute phase reactant. We often see it in fibrinolysis, but I don't know there's a huge amount of fibrinolysis going on here. And the D-dimers are actually a marker of severity as well. The higher the D-dimer, the more severe the COVID infection.
Yeah. Okay. So many people ask, well, is this disseminated intravascular coagulation, or it actually looks like very much like an antiphospholipid syndrome? Or what do you think? Are there features of a thrombotic microangiopathy? So yeah, it is very hard actually to compare this with the well-known coagulation defects that we do see in critically ill patients and patients with serious infectious diseases. What would be your take?
Yeah, I think this is really unique. This is a distinct COVID-induced coagulopathy. It's not typical of the DIC that we see. As I say, platelet count is usually normal, and fibrinogen is raised, as opposed to DIC, where we get consumption of those. And of course, inflammation and coagulation are intricately linked. And so the higher the inflammatory response, the greater the coagulation. And what we see is these microvascular infarcts, particularly in the alveoli capillaries, with tiny microthrombi there, which causes immense damage and adds to the ARDS, the adult respiratory distress syndrome, that we see with COVID pneumonia.
Yeah, I agree. And you know, the common response upon inflammation in terms of coagulation is that there is tissue factor exposure to the vasculature. It's being expressed by mononuclear cells. It can also be expressed maybe by endothelial cells, and thereby activate the coagulation system. There have been very interesting publications, the first one from the UK, but also internationally, that coronaviruses, in contrast to many other microorganisms, directly infect endothelial cells. Do you believe that that's an important factor as well?
I think that's a very important factor, and certainly the virus appears to infect many cells, endothelium and platelet. In particular, that's important when we're talking about coagulation. So direct endothelial injury, as you say, Marcel, will cause this exposure of tissue factor, which is the key trigger to blood coagulation.
Okay, thank you, very helpful. So this is the coagulation side of things and the coagulopathy that we see in patients with severe COVID. I think many people are interested in what's the relevance of all this. And I think it's no news to anyone that you do see a lot of thrombosis in patients with COVID-19, in particular severe COVID-19. Andrew, can you just give us an idea on how often in patients with severe COVID-19 we will see venous thrombosis of the legs or pulmonary embolism?
So thank you, Marcel. I think, in all honesty, it depends how hard you look and where you look, and whether you're looking prospectively or retrospectively for these thromboses. And actually, there's marked heterogeneity in the literature when you look through and put those criteria on it. But there was a review article in Chest published about 2 months ago, which suggested that we're seeing about a quarter of our patients having clear evidence of a macroscopic venous thromboembolic disease, a blood clot in their legs or pulmonary embolism in their lungs, and that's at least double critically ill patients beforehand. If I look back on our own experience in my institution, when we take patients who are very severely ill with severe respiratory failure, we always do a CT scan, and we saw 3 times the rate, perhaps even 4 times the rate of PE at presentation of these very sick patients who are intubated, ventilated, and on ECMO. So there's a very high thrombotic burden with COVID, particularly in the most severe cases. There is also a slightly increased risk of arterial embolic diseases as well, and so so it's markedly increased. Just picking up on something that Sue mentioned, I think what we see in the lungs and what was so different to us in ITU was that compared to patients previously with acute respiratory distress syndrome, these patients had relatively preserved lung compliance, and that's really strange. It's relatively easy to squeeze air into their lungs, but actually gas exchange was much more markedly impaired. And I think that speaks to what Sue was saying, because of this concept of immunothrombosis or microvascular thrombosis, which has been seen on post-mortem series. So the microvascular thrombosis is perhaps about 10 times more common than you'd see in normal ARDS. And then there's another series, again in the New England Journal, in about May last year, talking about neoangiogenesis or new vessel formation in the lungs. And that was, again, 2 to 3 times higher to what you'd normally see. And from an intensive care specialist perspective, we wonder why are these patients so hypoxic? We can get air into them, but clearly their gas exchange is the problem. And what we've shown is that there is increased shunt, that's blood going to areas of lungs that aren't ventilated, and increased dead space ventilation as well, where we're not perfusing areas of lungs as well. And so it's sort of a very complicated double hit injury to your lungs that this coagulopathy is causing us, and I think underpinning a large part of the pathophysiology of the disease.
Okay, excellent. And just to reiterate something you said, I think, which is important, there is a high risk of venous thrombosis, pulmonary embolism. There may be an enhanced risk of arterial thrombosis, like myocardial infarction and stroke, but it is a little bit more modest, isn't it?
Yes, it is. Yes, I'd agree with that completely. It's difficult to say. We have seen some patients with myocardial infarctions and indeed acute heart failure in the very sickest, but teasing that out specifically is a much harder thing to do. Okay.
Let's then move to prophylaxis and treatment of thrombosis in these patients. Prophylaxis first. So can you explain to us what the current thinking is about prophylaxis of venous thromboembolism in patients with severe COVID-19?
Thank you. So this was a huge topic of conversation at the beginning in the presentation of COVID, and how do you manage it? And many people very recently asked the question, we're seeing such a high burden of thromboembolic disease and microthrombosis, is there a role for enhanced thromboprophylaxis, perhaps called intermediate dose thromboprophylaxis, or actually full dose anticoagulation of these patients? And really, in a very pragmatic way, lots of societies produce guidelines. Certainly in the UK, we were really relatively keen on intermediate dose thromboprophylaxis, as opposed to more standard dose thromboprophylaxis, certainly in the sickest patients, because we'd seen such a high burden of thromboembolic disease. And I think we all have to admire the way the international research community has come together over the last year to produce studies, and we've moved from what was early reasonable hypotheses to actually testing them. And actually, with COVID and thrombosis, we've got really three studies that I really want to sort of touch on. That's the ATTACK study, the REMAP-CAP study, and the ACTIVE-4 study, all of which came together relatively early to sort of try and look at and address this this question of the benefit of full dose anticoagulation versus a thromboprophylaxis or standard thromboprophylaxis in these patients. And they subdivided their groups into looking at people who were severely ill. That's essentially patients who were in intensive care, those who were receiving high flow nasal cannulae, or on non-invasive ventilation or vasopressors, so quite a classical critically ill population. You have to remember that's probably 10 to 15% of these patients presenting to hospital. And then patients who were moderately sick, and they defined moderately sick as patients who were over the age of 18, admitted to hospital, had a positive COVID test, and were expected to be in hospital for greater than 72 hours. And there was some analysis done looking at Ddimers and seeing if risk stratification could be done to Ddimers, and that just reflects back to how high we've seen the Ddimers in this disease. And the first results from that were actually published just before Christmas last year. I think it was on the 19th or maybe 20th of December last year. And the key question they were asking was, if you gave patients therapeutic anticoagulation, did they have less organ support days? So the greater number of organ support days, the better. And I think everyone's assumption, well, certainly my assumption, was that actually full dose anticoagulation would probably be better there. But as a surprise, that was incorrect. And there was no statistically significant difference between organ support days at 21 days between standard dose anticoagulation, thromboprophylaxis, and anticoagulation. I think that was quite a surprise to a lot of us. They had a secondary endpoints of, perhaps combined endpoints, but looking at rates of venous thromboembolism, rates of bleeding, and rates of death at 90 days. Although there was slightly less VTE in the anticoagulated group, there was no difference in death at 90 days. And really the rates of bleeding were perhaps a bit lower in both groups than was expected, but they were low. And so that really was the sort of first evidence pushing us away from certainly a UK-based guidance for ITU that we use intermediate dose.
Yeah. Excellent. So it's such a nice illustration that although from a theoretical perspective, we may hypothesize that, so much clot, we should give more anticoagulation, higher doses, etc. And then we do a trial, and then the reality is a little bit different from our hypothesis. I think it's a wonderful demonstration. Sue, looking at you, is this also where you would arrive at? What would be your conclusion from this data?
Yeah, absolutely. I totally agree with Andy. I think while initially we thought that higher doses might be used, I think we've all come to the conclusion now that actually we prevent thrombosis when we need to prevent it with using prophylactic doses, and we treat it with therapeutic doses when we are treating it, and that's no different from outside the context of COVID anymore.
Yeah, excellent. And then the question which I see appearing in the chat and has also been submitted before and which comes up is, if platelets are so important, should we add something like aspirin or maybe clopidogrel to the current prophylactic regime?
Well, we just don't have evidence of that. And we do know that these patients are also vulnerable to capillary leak and pulmonary hemorrhages. And so, as you say, what may be sensible sometimes in theory is not borne out by clinical trials. And so we don't have the evidence to conclude on that at the moment.
Yeah, I absolutely have to agree with you. The good news, though, is that there are trials ongoing to look at the effect of aspirin or even stronger antiplatelet regimes, but it's too early to tell. And awaiting that evidence, there is no good reason to do that at the moment. Yeah. Excellent. So just looking at both of you, many people wonder that if thromboprophylaxis is advised and is effective in patients admitted to hospital and to ITU, shouldn't we give it to patients who turn up in A&E, have confirmed COVID, but are then sent home and may actually spend a lot of time in bed at home?
Who's going first?
Yeah.
Well, again, I think there's no evidence for that at all at the moment. And remembering that in prevention of venous thrombosis, heparin is only 50% effective. So I think a lot can be gained from general advice and patient knowledge and information about the importance of good hydration, feet and ankle mobility to encourage venous return, and general measures to prevent venous thrombosis rather than medicating everybody with early COVID.
Excellent.
Yeah, okay. I'd agree with what Sue said there. I think it's very difficult to pick these patients. We've used the D-dimer, the CRP and ferritin to try and risk stratify patients. And I think it's safer perhaps if you're concerned to admit people for 24 to 48 hours and observe their progress rather than try and rapidly push them home. I completely hold my hands up to the business that it's been in the waves of the pandemic, and how that's an easy thing to say, but practically harder to operationalize. But I agree with what Sue said.
Brilliant. Okay, before we move to the vaccines, just one final question. We know, of course, that some people have a higher risk of venous thromboembolism because they have thrombophilia or they have a history of venous thromboembolism. Should we be very extra careful in these patients, or do they have, well, more or less the same risk of having thromboembolic complications when they have COVID?
I mean, I think it's always prudent to be extra careful in patients with known thrombophilias as well. Of course, there's a whole spectrum of thrombophilias, some being very mild, like factor V Leiden, and some being very significant, like antithrombin deficiency or antiphospholipid syndrome. So I think when it comes to COVID, as in any medical setting, the risk of thrombosis needs to be weighed up and individualized for the patient, and taking into account many patient factors as well as their clinical factors with their presentation.
Okay, thank you. Okay, let's in the interest of time, let's move to the vaccine issue. I think everybody knows that we were surprised by a new syndrome, to say so, appearing after, in particular, the AstraZeneca vaccine. where patients about 1 or 2 weeks after having had this vaccine presented with odd thrombosis, to say so. This is venous thrombosis, but at unfamiliar sites like the cerebral sinus veins, and sometimes also mesenteric veins and well, other unusual sites, accompanied by thrombocytopenia. And we will come back to the mechanism in a second, but let's just first focus on the epidemiology. What's the current thinking how rare or how frequent this is occurring, Sue?
Well, in the UK, we've seen over 200 cases now, and we have set case criteria so that we're not over-reporting or under-reporting. We are detecting them all properly. So our case definition is really the presence of thrombosis. When I'm talking about the vaccine-induced immune thrombocytopenia and thrombosis, it is thrombosis with thrombocytopenia in a time limit after vaccination. So we say between 5 and 28 days, although we are also assessing patients who might present earlier or present later. So we're keeping an open mind about what this case definition might be. And they also have evidence of a coagulopathy with a reduction in fibrinogen and very raised Ddimers beyond what you might expect for that degree of thrombosis. But just to say also that the thrombosis is really quite aggressive and very progressive. And we've had one neuroradiologist describe doing a thrombectomy, and as he was sort of pulling out the clot, more clot was forming. So it's a very aggressive disease process.
Yeah, scary. And we'll come back to this important syndrome in a second, but just to put that aside and thinking about conventional venous thrombosis, pulmonary embolism, is that more common after COVID vaccination?
In outside the context of VIT, it doesn't appear to be at the moment, but the MHRA and Public Health England are keeping a very close eye on the statistics, and they use the yellow card system, which seems to be working very well to monitor all cases that are presenting following vaccination. And it's not just thrombosis either. There will be immune reactions, neurological reactions, and autoimmune conditions like ITP and autoimmune hemolytic anemia. So whether they have increased incidence after vaccine is really being monitored at the moment very closely by the MHRA.
Yeah, which is excellent. And just to maintain the balance between the risk of these side effects on one hand, but of course also the benefits of the vaccines on the other hand, it's good that we realize the real incidence of all these complications. And you mentioned for the vaccine-induced thrombosis, thrombocytopenia, that it was 200 cases in the UK on millions and millions of people who received the vaccine. And there is an age distribution, I think, which is important to mention.
Yes, that's right. We're seeing it affecting quite young ages. So the median age of our cases is actually 49, which is relatively young. As you know, thrombosis increases with advancing age. It appears to affect males and females equally, and it can affect all ages. But the fact that we're seeing it in young cases where less young people have been vaccinated, then that incidence is really important to understand, and that's what the MHRA are looking at.
Brilliant. And Andy, if I may ask you for a kind of a practical approach. So we are being confronted in A&E or in surgery with a patient who presents with, neurological complaints, maybe even thrombosis. And how do we ascertain that this is vaccine-induced thrombosis, thrombocytopenia, or how can we exclude the diagnosis?
Well, the first thing I'd say is actually, I think Sue's been a little modest. I think we've known this condition existed for about 7 weeks or maybe 8 weeks now. And it's a remarkable success story that we've been able to study it so quickly and publish and show stuff so quickly. And And if people want further information, there's guidance on the BCSH website that they can look at, and triage criteria they go through as well. But specifically answering your question, Marcel, VT is common. It's one of the most common presentations to hospital anyway. And when we've had these patients referred to us in critical care, one of the key criteria I've said to people is to look at the thrombocytopenia. These patients should be thrombocytopenic. And if you look at the 3 articles that were published in the New England Journal of Medicine in quick succession, the patients were quite severely thrombocytopenic. The platelet counts generally between sort of 20 to 50. And I think that's a key thing for me. The second practical advice I've been giving people over the phone is to make sure they speak to their local haematologist, and then think about make sure they're clear on the timing of when the patient got the vaccine, and then progressing to do the test for the platelet factor 4 antibody. And the little caveat and warning that comes to everybody here is that the sort of rapid diagnostic test for that can frequently be negative. And so it's really important to have that conversation with your local haematologist to make sure you're doing the right test for platelet factor 4, and perhaps to question your initial result. But also, and Sue can correct me if I'm wrong on this, I think that every case we think we identify, we're supposed to signal to the expert panel or notify them. And we've got the yellow card reporting system too. And so help is available. But yeah, looking for the platelet factor 4 antibody and the platelet counts particularly important, I think.
Excellent. So that's very practical advice. So it starts with a clinical presentation, then think about the timing towards the vaccination. Then there should be thrombocytopenia, which could be really pronounced, let's say less than 50,000. And then you can do a test, but it depends a little bit on the tests that are being run in your hospital. So talk to your hematologist. They will probably know whether their test or another test should be done. And then it is not too difficult to make a diagnosis. Yeah, and from what you're saying, we're touching already upon the underlying pathogenesis. And it's indeed amazing that just, very few days after the first presentations of these patients, groups were already finding out the underlying pathogenesis. And it seems that there is an autoantibody after vaccination being formed, which is directed to platelet factor 4, which is an endogenous protein that's present in the blood, in platelets, and in endothelial cells. And interestingly, if this antibody that's being formed by affected patients binds to platelet factor 4, it does 2 things. It activates these platelets, and this leads to this very aggressive thrombosis formation. And at the same time, platelets are being consumed, and that's the reason that there is a thrombocytopenia. This mimics actually a disease that we know very well, and that is a disease that when some patients, also quite rare, are being given heparin, and heparin is a drug that binds to endogenous platelet factor 4, you can make an antibody towards the combination, about the complex of platelet factor 4 heparin, and then you get the same thrombocytopenia and thrombotic predisposition. So, but this is different because most patients after vaccination did not have any heparin exposure. So this is a direct anti-platelet factor 4 antibody. And this was important information because, and I'm looking at you, Sue, if we are being confronted with such a patient, this guides us a little bit in how to manage them. Can you summarize, Sue, what you do to manage these patients?
Yeah. Just first of all, adding to Andy's earlier point about patients presenting with symptoms, and we were expecting as soon as the communication to the public went out in early April that ED departments and GPs would be inundated with understandably worried patients, because it's quite common to have symptoms after the vaccine, and they may or may not be representative of it. And so what was put in place in the UK, which I think has been fabulous, is guidelines for ED departments, so that this really supports patients. And it's saying if there is a patient who presents with a sudden onset of headache or worsening headache after 5 days since the vaccine, then they should have a platelet count. And if that platelet count is normal, they can go home. They don't need to be scanned or have a head scan at that time. They can go home with the safety net that they can come back the next day if their symptoms are worse or have not gone away or they're still worried. So that provides support for patients while rationalising our resources and not being, too frightened that we're going to find this very rare condition in everybody who presents with symptoms. So the platelet count is key, just as Andy said. Now, if the platelet count is then low, we will go on to do fibrinogen and Ddimers and ultrasound and CT venogram of the head, and ultrasound also looking for portal vein thrombosis, and considering DVT and PE, which are the second most common thrombotic events after cerebral venous sinus thrombosis. So having diagnosed VIT, our first line treatment is intravenous immunoglobulin. And that raises the platelet count pretty successfully and appears to stop or slow this autoimmune process. We are finding now that repeated doses of intravenous immunoglobulin are required because this, as you've said, Marcel, this is an aggressive process and it can be difficult to turn it off. It becomes self-perpetuating as more platelets and monocytes are activated, more platelet factor 4 is released, and it can be self-amplifying. So we have found that repeated doses of intravenous immunoglobulin are required sometimes.
Excellent. And in the beginning, people said you have to avoid giving platelet transfusion. Is that still true?
We think so, and that's always been our thoughts with heparin-induced thrombocytopenia, because giving more platelets provides more substrates and more platelet factor 4 and may further perpetuate the prothrombotic state. However, there is quite a high need for neurosurgery in these patients, and the neurosurgeons would obviously be very worried about such thrombocytopenia when they're doing major surgery, and so it may be necessary in these cases to actually give a platelet transfusion to allow neurosurgery to be done as safely as it can be.
Okay, and then lastly, since this is so close to heparin-induced thrombocytopenia, can we give heparin to these patients?
That's a very good question, Marcel, and I'm desperately keen to get to the answer quickly. So the pattern that we see with the platelet function test is different from heparin-induced thrombocytopenia, because as you've said, it occurs in the absence of heparin. And so just the incubation with serum on the ELISA plate will cause a strong reaction. When we then give some heparin to that, the reaction is a bit less. So it seems that the heparin may also have some slight inhibitory effect, or whether it's dilutional. And just with heparin-induced thrombocytopenia, when you give a really excessive heparin, it is inhibited. It seems to break up these platelet factor 4 multimers. Now, we have had cases who inadvertently have been given heparin, either prior to our knowledge of this condition. As Andy says, we've only known about it for 6 or 7 weeks. And I've asked all of those clinicians, in their experience or with their cases, did they think heparin made it worse? And not one of them has said, I felt the heparin made it worse. So we're hoping heparin might be okay, but it's just too early for us at the moment to be able to come off that fence.
Okay. And fortunately, we have alternative anticoagulants if there is
yes,
if they need. Yeah,
we do.
Okay. So let's move a little bit into the direction of questions. And there's a couple of questions, and this is also very relevant, I think, for clinicians, saying, well, this is mostly seen, or maybe exclusively seen, after the first dose of the AstraZeneca vaccination, maybe the Janssen vaccination, but just after the first injection, and not so after the second injection. Is that still true?
That certainly appears to be the case, but obviously less people have had a second vaccination, and it is a rare condition. So we are always looking out. We've had about 5 suspected cases after the second vaccine. And when we've looked at them closely with our case definition, then they haven't turned out to be VITs. And we, in theory, it might be much less likely anyway, because if this profound immune reaction didn't happen after the first dose, or even if it did, but they were what we call VIT non-responders, their FC receptors perhaps don't respond in the same way to the platelet factor 4 antibodies. And we see that in heparin-induced thrombocytopenia, of course. Then they're not going to get it after the second dose, but we're constantly monitoring the situation. And as you know, it's all very new to us.
Yeah. Yeah, and there is a lot of, well, actually we have a huge amount of questions, but there is a lot of questions which are very relevant and of people who are asking themselves, well, isn't that strange? If this is an immune phenomenon, I would expect that a second dose would actually boost that immune response also to platelet factor 4 antibodies, but that doesn't seem to be the case, which is intriguing. And I think I think nobody can give an answer to that. And the other thing is that we also do not understand why younger people are much more frequently affected than elderly people, other than in terms of, well, younger people have a stronger immune response than elderly people. But that's still not a satisfactory answer, maybe.
But it is interesting because it's quite different from the populations who really suffer with COVID infection. It seems to almost be the opposite.
Yeah, yeah. And maybe for both of you, Sue and Andy, so it is actually a bit puzzling that this occurs after vaccination and that clotting is in itself and thrombosis are also such a big problems in COVID infections. Mm-hmm. So is there a link between the two, or is it just coincidental? What would be your take?
Well, I think one of the first questions was to look at whether platelet factor 4 antibodies are actually present in people with COVID infection, or particularly COVID infection plus thrombosis plus thrombocytopenia. And in the cases that we've studied at the moment, so the vaccine trial, over 376, I think, vaccine trial samples have been tested. There's no platelet factor 4 signal there. Obviously, it's a rare condition and there's a numbers game there. We might simply not be testing enough of them. And when we've looked at a few cases of COVID infection plus thrombosis plus thrombocytopenia, platelet factor 4 antibodies were not present there. But there is a wider look back going on to see whether this could have occurred with COVID infection, but it doesn't look like it at the moment.
Okay, brilliant. And while we're speculating, why only after AstraZeneca? Why doesn't it happen after Pfizer or Moderna? I'm only asking difficult questions. I'm sorry.
I don't know. It's important to say that they're very different vaccines, aren't they? The Pfizer and Moderna vaccines are RNA-based vaccines. I think it is reported. I think there are a few reports, and Sue probably knows more with the Johnson & Johnson vaccine in America. I think there are 5 there. Those are both adenovirus vector vaccines. And that might be part of the explanation, but I don't think we really know. And going back to the last question, I do think it does appear to be an idiosyncratic reaction and at the moment.
Yeah. Okay. So I do get loads of emails from all kind of patients asking questions. I'm sure you're getting the same. And a lot of these questions are actually also mirroring questions that I see in the chat and that have been sent to us before. If you get an email from someone who said, I had a thrombosis in the past, I have a high risk of thrombosis, I have a high risk of autoimmune diseases, can I safely take the AstraZeneca vaccine, or would it be better to ask for another vaccine? So what would be your responses?
Just going back to my earlier comment, it does appear to be an idiosyncratic reaction, and yes, it is safe for those patients to have the vaccine. Indeed, the benefits of having the vaccine we only have to turn on our TVs and see what's happening to the poor people in India where they have much less vaccinations than we've been fortunate to gain access to in the UK. It's very important that they get their vaccine. That would be very much the advice I'd give to them.
Okay, Sue, what do you think?
Yeah, I would fully support that. We've looked at our 200 cases, and there is nobody has had known thrombophilia, antiphospholipid syndrome. There were 1 or 2 prior history of DVT and PE, but that was not greater than would be expected for that group. So it does not look like any prior thrombosis or prothrombotic disorder increases the risk of having this immune reaction to, and I think it's important to just emphasize it is an immune reaction.
Okay. And doctors always want to do things when people ask them a question, and right or wrong, with the best intentions. So some doctors now say to their patients, well, why don't you take just a little bit of aspirin just before you get the injection, the vaccination, and a few days thereafter. What do you think?
My advice would not be to do that. With CVST comes intracranial hemorrhage due to the extent of the thrombosis and back pressure. And intracranial hemorrhage is life-threatening. It's what many of the deaths have been from. So I wouldn't be taking any kind of blood thinning or antiplatelet agents prior to vaccine.
Okay. You wanted to come in, Andy, or you agree?
I could just say I completely agree with what Sue said there. It's an idiosyncratic immune reaction, and an aspirin or an anti-inflammatory is probably going to have no effect on it whatsoever, and might even be harmful, as Sue said.
Yeah, I also agree with you. Let's just keep our heads cool and not make things worse. Actually, again, with the best intentions to protect patients, it could actually have a lot of negative side effects. Okay, let's go to a couple of other questions on some of the more exceptional situations. What about pregnancy? If you're pregnant, is there any reason not taking the COVID vaccine? And if you take the COVID vaccine, which one would you prefer?
Well, we would advise in pregnancy to actually take the Pfizer vaccine, really because there's been good experience of this overseas and in the States. So that would be our preference at the moment for pregnant women.
Okay, excellent. I'm looking at the list of further questions. There's plenty of them. Yeah, well, this is a very difficult question, but I think it is relevant, very relevant.
Give it to Andy then, Marcel.
Okay, well, Andy, this is really, really difficult. So we now know a little bit about the mechanism of this vaccine-induced thrombosis, thrombocytopenia. Why cerebral vein thrombosis? Why not just, conventional thrombosis that we see so often?
I have had this question asked to me before, and the honest answer is I don't really know. There must be something specific. Is it, I don't know, related to flow, particular phenotype, something subtly different about the endothelium there, but I don't honestly know. I'd be interested if Sue has any thoughts, but I don't know the answer to that question, sorry.
Well, what's interesting about heparin-induced thrombocytopenia is that where the thrombosis happens, it has a predilection for where the abnormality is. So when we give unfractionated heparin to people having cardiac bypass surgery, for example, their thrombosis will be in the coronary vessels. If we're giving unfractionated heparin to somebody post major orthopedic surgery, their thrombosis will be in the venous circulation. So we don't really give unfractionated heparin to young people, but you can imagine if we did, perhaps it would be the cerebral venous sinus thrombosis that we see in those cases. Is there something vulnerable about the cerebral venous system in young people that, like Andy said, the flow or the endothelium or something that makes it a vulnerable site in young people?
Yeah. The interesting thing about cerebral vein thrombosis is that it's rare, but there is an excellent collaboration across the world. So there is a large database where all conventional cerebral vein thrombosis are being collected. I know from these investigators that they've looked at antiplatelet factor 4 antibodies and they don't find them. Yeah. So this is really a distinct disease, like you said in the beginning. Yeah. Last question, and this is about policy. So the UK government, after advice from MHRA, has decided not to give AstraZeneca vaccine to those younger than 30 years old. What do you think of this threshold? Is that well chosen? Would you have chosen something else? What are your views?
I mean, I think it's very concerning, isn't it? This disease in young people who are perhaps less at risk of COVID infection itself, and certainly in being hospitalised with it. And that's why I think the MHRA are really keeping an eye on the cases, and they are looking at age-based incidences of this condition compared with the numbers vaccinated, and comparing that with statistical modelling of COVID-19 infection and fatalities per age group. It may well be that they increase the age cutoff.
Okay. Andy, what's your view on this?
I think it's very difficult, isn't it? I'd agree with what Sue said, or what Sue just described. I would reflect that we're incredibly lucky that we've got an open reporting culture and that we're trying to collect all these cases. And actually, I think the answer will become clearer to us with time. We'll know both the numerator and the denominator better, so we can make more informed decisions. And you know, the risks of COVID, I quite often send some of my friends to look at the Q-COVID score, where you can work out your risks from COVID online, and they're hugely different from if you're a 70-year-old, if you're a man in your 70s and are heavily overweight and a smoker and got other risk factors, as opposed to a young, fit lady in your early 20s. You know, there's quite marked difference, and how we tease that out and apply that, I think we'll just learn more with time. At present, the thresholds seem very sensible to me, and I'm very happy to respect them.
Yeah. And just to finish this topic, we should not forget that this is a discussion because we do not have excessive numbers of vaccines. So it's still a shortage worldwide, but even in the UK. So that means if we would have a choice, then we would probably give something else. But we are still having, you know, a paucity of vaccines. That will change over time, of course. So I can understand if people younger than 30, or maybe people who are 30 and have no risk factors for COVID say, well, I'd rather wait until I'm eligible for another vaccine than the AstraZeneca vaccine. But that's, yeah, time will tell. Time's up. I'm afraid we have to stop. And I have to apologize because I see there's more than 100 questions. We've tried to answer some of them, but there are many, many more. So maybe we have to repeat this session at another time to see whether we can address even more questions. For now, I would like to thank the Royal Society of Medicine for organizing this mini symposium. I'd like to thank Sue Pavord and Andy Retter for answering all these questions and participating in the discussion. I'd like to thank all of you. We have an enormous amount of listeners to this symposium to attend and to ask all these interesting questions. And we will finish just by telling you that next week there will be another Royal Society of Medicine symposium. The topic of next week is pandemic responses around the world, and there will be speakers from Australia, from Israel, and from Brazil. For now, that's it. Thank you all very much for your participation, and enjoy the rest of your day.
Thank you very much.